Good evening, friends. Welcome to this Tuesday academic sessions from City of Hyderabad, from Yashoda Hospitals and ISCCM Hyderabad City branch. So we have been doing it for the couple of years to benefit most of the widest need of the student category. So we have been successfully able to conduct these classes across the year. So for today's discussion, we have an interesting topic like infections in immunocompromised host. The reason why we thought to bring this topic is many of the times our students, when they get a case in the ICU, when a post-transplant liver or a renal transplant patient has been given to them, or a patient who has been post a malignancy surgery and put on to some chemotherapy has been given to them, many of them get taken away, and that nervousness actually makes them completely drop down in many of those performances. So we felt this is one of the common scenarios which we come across in the ICU, as many of these complex procedures like transplants are building up in many of our hospitals. These patients tends to come to our ICU more often nowadays. And also the surgical complexity has gone up, and we are seeing more and more surgical oncology and chemo patients, and even in hematopoietic stem cell malignancies, transplants, bone marrow transplant, and patients like that. So the purpose of this discussion was to actually make our students oriented to this kind of cases which comes regularly to ICU. And to bring these discussions, we have none other than Dr. J.V. Peters, sir, who has been the Dean and Head of the Critical Care Medicine, and what an academician he has been throughout our maybe our student career to till now. Sir, it is our honor and pleasure to have you here on board, sir. Thank you for being a part of this. Dr. J.V. Peters, sir.
Thank you, Dr. Venkat, for inviting me. It's indeed an honor to be part of this session, and it forced me to go back to the books and read up to see what is new. So thank you for this invitation to be part of this.
And the other teacher and academician and also a good friend of mine, Dr. Siva, who has been carrying all his greetings from city of Coimbatore, owning an entrepreneurship and also leading a hospital. So welcome, Dr. Siva, on board.
Thank you, Venkat. Thanks for the opportunity, Venkat.
So we have two students, Dr. C. Goutham and Kausalya, who will bring this case to us. So the purpose of this discussion is they will put across a case discussion, sir, and it will take, both of you can take through as an exam pattern, and both of them can answer and part of it. And we also see a lot of queries and questions in the chat box and answers. So one of you, when you are not actively asking, so that they can roll through that, sir, so that you can participate. And over to you, Dr. Goutham and Kausalya, and over to the moderators.
Good evening, all. Today we are discussing a case of infection in an immunocompromised host. So this is a 40 years old male patient who is a resident of Hyderabad, who works as a computer operator. He presented with the chief complaints of cough with expectoration, which was yellowish in color, not foul smelling, and not stained with blood. Fever, which is high grade and not associated with chills and rigors, with no diurnal variation. And there is a shortness of breath, which was progressed to grade 4, initially to start with grade 3. And loose stools, watery in consistency, not associated with blood or mucus, and not foul smelling. There is no history of pain abdomen, urinary disturbances, night sweats, or loss of weight and appetite. In the past history, there was no significant past history, and he's a known case of retroviral disease who was not on any ART therapy. Family history, there is no significant family history. Drug history, he took ART for 2 days and then he was non-compliant to the therapy. In the personal history, he is not a known smoker, alcoholic, who consumes mixed diet. His bowel and bladder habits are normal. On the general examination, he is thin-built, moderately nourished. There are no pala, icterus, clubbing, cyanosis.
Can I stop you there to ask what are the differential diagnoses you consider in a patient who has an underlying immunodeficiency disorder when they come with features of respiratory infection?
Sir, as this is a case of retroviral disease, the patient who presents with fever and SOB, our most the differential diagnosis will be pneumocystis pneumonia. which is the most common in the RBD patients, and also any bacterial pneumonia also, or the common like Streptococcus pneumoniae, Haemophilus influenza.
So why do you list pneumocystis as your top differential? Is that the top differential in a immunocompromised host like this? Bacterial infections are still more common than the other opportunistic infections, and we don't have enough information to say how immunocompromised this patient is, because the type of infections is dependent on what in an individual who is HIV positive. What determines the type of infection?
His CD4 count will...
Yes. So based on the CD4 count, the type of differentials that you would consider are different. So if you want to rank your list of differentials in a person, was coming with how many days of duration of symptoms?
He presented with 5 days of symptoms initially.
So it's a short duration viral illness with rapidly progressive breathlessness and cough with sputum production. So if you want to list in a rank order the types of infections, what would your differentials be? I'm not saying it cannot be pneumocystis, but if you want to put down your list of differentials, what would you consider?
Most commonly in community acquired pneumonia, sir, like bacterial, like Streptococcus pneumoniae, Haemophilus influenza, and any viral pneumonias, influenza virus.
You're right. Actually, community would say it's a community acquired pneumonia. If there are signs of pneumonia, we haven't come to signs yet. We're still at the symptomatology part of it. So whatever differentials you said as bacterial and viral will be top on the list, and bacterial, the whole spectrum of infections will still be common, including pneumococcus, H influenza, and other infections. Dr. Sivakumar, you want to add anything more to this at this point?
I just want to check with Goutham, sir. In the history, what is against PCP? I think you elaborated on the history. So one thing which is very distinctly against the course of PCP.
Cough with sputum. Usually they will present with dry cough.
Okay. Here you're given a history of an acute breathlessness, shorter history, which is again against the course of a PCP. Normally, you do see a more of a subacute, which develops over a period of couple of weeks. That's what is classical history with PCP. So that is again, which goes against PCP. Okay.
Okay.
So you can proceed.
Proceed with the examination and see. Let's see if we can hone in on the differentials a little better. Continue.
His vitals were BP blood pressure of 116/74 mm of mercury on right arm in supine position, pulse rate of 99 beats per minute, normal in volume, regular in rhythm, with all peripheral pulses being felt. His temperature was 101 degree Fahrenheit and respiratory rate of 22 breaths per minute, with saturation of 90% at room air, and he was maintaining a 96% with 10 liters of oxygen and with intermittent NIV support.
Sorry. Just tell me why go back to the slide. Saying respiratory rate of 22 and hypoxic. No tachycardia. Is a hypothetical situation or it's a real patient?
No, it's a patient only.
Sorry?
It's a patient only, sir.
Patient whom you have seen?
Yes, sir.
Okay. So why would you start somebody on an IV support when the patient is breathing only at 22 breaths per minute? We are covering a little more than infection alone.
Goutham sir wanted to know, his respiratory rate is 22, his workup breathing is not high. Why are you supporting him with non-invasive ventilation?
Only it was only the intermittent NIV support was a plan, sir.
Okay. Okay. So
initially only we started on 10 liters of oxygen with NRBM mask only, sir. That's it. But the plan was to with intermittent NIV was this.
Okay, no problem. I mean, there are ways of justifying this, but we'll proceed. Proceed to the next part.
His airway examination, mouth opening is more than 3 centimeters. His myopathy grade 2 and he has normal dentition. In systemic examination, apex beat is palpated at the fifth intercostal space, mid-clavicular line, auscultation, hot sounds are S1, S2 are present, no murmurs or trills are present. In the respiratory system, trachea is in the midline, bilateral normal vesicular bed sounds are present, preparations are present in the bilateral infrascapular region. There are no V's, rhonchi and crackles.
Proceed.
The CNS examination, patient is conscious and oriented to time, place, and person. Higher mental functions are normal. His cranial nerve examination there was no abnormality, and there was no sensory or motor weakness present. And abdominal examination, abdominal examination is soft, non-tender. There was no organomegaly, and all hernial orifices are normal. So with this, we came to a provisional diagnosis of severe community acquired pneumonia with type 1 respiratory failure, with a viral or bacterial with acute gastroenteritis.
So on what basis have you said severe? So how can you classify severity of pneumonia? What do you know of any method of classifying whether they're mild or moderate or severe, and what is the need to classify them as mild, moderate, or severe?
With the need is whether we can treat them on a OP basis or what basis, or those who require ICU admissions.
Okay. So what are you using to say it's severe? What criteria are you using to say it's severe?
So,
have you heard of curve 65? If you want to use a conventional. Sorry, Dr. Sivakumar was asking something.
No, sir. So, are you aware of any severity scoring system for community pneumonia? That's what sir is asking about. What are the severity scoring system you are aware of for community pneumonia?
CPA score.
I think you should know some. You should go and read up some of those severity scores. Clinical pulmonary infection score you can use.
CPS.
You can yeah, that's what CPI is. You can use curve 65 because is it severe? Do you know the components of curve 65?
Confusion.
Yes.
Age
No
more
confusion
than
there.
65.
Age.
Age more than 65.
Okay, it's not more than 65. Urea. So if you look at this patient, he is not meeting the C criteria, U criteria, R criteria, blood pressure criteria, or 65 criteria. So on what basis are you saying severe? Is it only based on the fact that patient is hypoxic at admission? So you should be very careful when you make a dogmatic statement that it's severe. There are some elements in your findings which are also not congruous in terms of a saturation of 90% with a respiratory rate of 22, no tachycardia. Those also not quite congruous. I guess it can happen, but any hypoxia to that extent means your PaO2 is less than 60 if you look at the oxygen dissociation curve. So that is not really congruous. Okay, I will dispute this to say severe community acquired pneumonia. I would just say community acquired pneumonia with type 1 respiratory failure and go forward. Dr. Shashidhar, you want to ask anything or add?
Nothing at this point. So probably maybe he's taken the host factor, but most of the severity scoring system do not take host factor into account when you decide on the severity of illness. So probably based on any one of these factors in curve 65, or you can use other scoring system like pneumonia severity index. So probably they take multiple factors into consideration, but none of them take the host factors like these immunocompromised state for severity prediction. how good, suppose you assume that probably this patient becomes subsequently hypoxic, not requiring higher amount of oxygen support. I think how good is the evidence to support them with non-invasive ventilation? Someone with hypoxic respiratory failure in the background of an immunocompromised state. How comfortable are you? How good is the literature support?
You don't know the answer, just say I don't know, so that we can at least cover as much as possible. Because it's exam focused, we are trying to cover as much ground as possible.
Actually, we can try non-invasive ventilation in these patients who are hypoxic and who are, means they're conscious, so he's conscious oriented.
I'm just asking you, in the context of an immunocompromised state and a hypoxic respiratory failure, how good is the literature in favor of non-invasive ventilation? I think earlier recommendation used to be very strong for immunocompromised patients with regard to non-invasive ventilation, but subsequently we have come across many papers, probably which do not have such high robust evidence for usage of non-invasive ventilation in immunocompromised patients. But so if you take recent guidelines, even ISCCM has got a guidelines with regard to usage of non-invasive ventilation, they give a milder recommendation, a weaker recommendation with regard to usage of non-invasive ventilation in immunocompromised. Okay, Goutham will proceed.
Investigations, patient investigations, hemoglobin of 11.5 grams, WBC of 8,600 cells per millimeter cube, platelets was 3.12 lakhs per millimeter cube, PT is 17 seconds, INR is 1.73, blood urea 17 milligram per deciliter, serum creatinine is 0.73 milligram per deciliter. His electrolytes were sodium 134, potassium is 4.3, chloride was 99.8. His LFTs are as follows: total bilirubin 0.48 milligram per deciliter with direct of 0.11, indirect 0.37. SGOT, SGPT is 12 and 14. Alkaline phosphatase of 68. Albumin of 3.5 milligram per deciliter and globulin is 4.6. His CRP is 3.8. Procalcitonin is 16.08. Virology is HIV positive, HbSAg and HCV are negative. He has an LDH of 683, D-dimers of 318, ferritin is 36.9, and his CD4 count is 160.
Why did you do procalcitonin? For this patient, why was procalcitonin done? How could you substantiate that?
He presented with a high-grade fever on presentation, acute presentation.
Okay.
With a background of HIV positive, immunocompromised also.
Okay. So you want to differentiate between viral and bacterial? Can you use procalcitonin?
Yes.
For that?
Yes.
Would you use procalcitonin for that? Is it recommended to do that way?
No, not recommended.
Okay. Then what is the reason to do the procalcitonin? How can you substantiate? Still, you could substantiate. So
this is a baseline procalcitonin response to the treatment.
okay. Okay. So
Antibiotic, what we are starting.
Before starting.
the only indication to use a procalcitonin in patient with community pneumonia is to decide on de-escalation or the duration of therapy. So I think unless you have a baseline procalcitonin, then you can't look at the percentage of fall. So I think if at all it is used, it should be used for that indication. It should not be used for starting antibiotic or differentiating between different etiologies of community pneumonia. So, okay, go ahead.
ECG was within normal limits. 2D echo showed no regional motion abnormalities. EF of around 60% with good biventricular function. Chest X-ray showed a homogeneous opacity in the bilateral lower zone. CT chest showed multifocal ground glass opacities in bilateral lungs. consolidation atelectasis of basal bilateral lobes and the posterior segment of upper lobe. Ultrasound abdomen was normal.
So you said about PCP. Can you go back to the X-ray?
Yes.
So what is the finding you expect in PCP? Does it correlate with it?
PCP usually will have a bilateral ground glass opacities with reticular pattern, sir. With the subpleural regions will be spared with PCP.
Okay.
Perihilar region is the most common involved.
So usually it starts around the hilum and it probably distributes peripherally. So, okay.
So patient was initially, he was admitted in wards here and was started on ampicillin sulbactam, 1.5 grams IV Q 12 hourly, injection fluconazole 100 mg Q 12 hourly, cotrimazole tablet 8 hourly, and metronidazole 500 mg Q 8 hourly. He was initially managed in the room for 2 days, where he was requiring 2 liters of oxygen, with which he was maintaining a saturation of 96%. He had a continuous fevers of 99 degree Fahrenheit, and there was a worsening of SOP, for which he was being shifted to the ICU.
Goutham, you want to give the rationale for the antibiotic chosen? You're given an empirical therapy. Okay.
Yes.
Can you give the rationale for these antibiotics, on what basis these antibiotics were chosen?
So they were, actually they were started by the physician in the wards.
Okay. Can you just try and tell?
Okay.
We are more prone for gram-negative infections. More the HIV patients are more prone for gram-negative infections. Immunocompromised patients, basically.
Okay.
So usually start with the cefixime monotherapies like cefixime initially, or piperacillin tazobactam monotherapy. If not responding, or if there is an extended spectrum beta-lactamase activity, then they can go till carbapenems like meropenems. So they have started, I think, with ampicillin sulbactam there.
Sorry, you want to add on, sir?
See, you said it's community-acquired pneumonia.
Yes.
And what is the standard therapy for somebody presents with community-acquired pneumonia? Immunocompromised or immunocompetent is secondary. It is important. I'm not saying it is not important, but in a short duration febrile illness, my understanding is that even in the immunocompromised host, the bacterial infections are more common than the opportunistic infections. So if that be the case, what would your initial choice of antibiotic be? Okay, we'll give it to you that the physician started. But if you are the first portal of call, what would your choice be? What and why?
Fluoroquinolones will be
piperacillin tazobactam. Why would you want to choose piperacillin tazobactam? If you want to choose that.
So my choice will be a fluoroquinolone, sir.
Which one? And why? Which fluoroquinolone and why? So you want to cover broadly the common organisms that cause pneumonia in an individual, a community-acquired pneumonia, which are the gram-positives, the gram-negatives, gram-positives and gram-negatives, and atypicals, isn't it? So Streptococcus pneumonia, H. influenza, and some atypicals. Okay, so piperacillin tazobactam with an atypical cover like azithromycin would be your broad spectrum coverage for a community-acquired pneumonia. Yes, I agree with you. There are very many atypical features in this. But how do you justify the use of fluconazole, cotrimoxazole, metronidazole? Why metronidazole?
Patient has a history of gastroenteritis. So for anaerobic coverage, they have added metronidazole.
So are you saying he's got two illnesses, gastroenteritis caused by some organism and the respiratory infection caused by something else? Doesn't make sense, no?
Probably many of these common things like influenza can present with gastroenteritis. So it could be your influenza just presenting with the GI symptoms.
Yeah.
Yes, SAR said, I think these are the organisms you should try and cover. H. influenza, your pneumococcus, staph. Probably these are the organisms, and rarely atypicals like Legionella or Nocardia, particularly if your CD4 counts are very less. So I think we talked about CD4 count. I think now you got your CD4 count. So it is quite low. So based on these CD4 count, I think you can narrow down your suspicion of certain organisms. Like Nocardia is common if your CD4 counts are very low. You don't think of Nocardia when your CD4 counts are 500 or above. So, but if you have your counts like less than 200 or 150, that is the time you think of PCP, you think of Nocardia. So I think so. Yeah. Common things are common. Probably you have to target your bacterial and viral pneumonias, and based on your CD4 count, I think you need to cover some rare pathogens like Nocardia or PCPs that needs to be covered. But I think that there is no rationale to add fluconazole or metronidazole in this patient.
I fully agree with Dr. Sivakumar. Okay, now move on to the next.
On day one, a pulmonary referral was taken, and we have escalated the antibiotics, and it was started on meropenem 1 gram 8th hourly, clarithromycin 500 mg 12th hourly, Fluvi 150 mg Q 12th hourly, and we continued cotrimoxazole, and we have escalated fluconazole, and we started on a steroid injection methylpred 40 mg only. We have sent for H1N1, RT-PCR, beta-D glucan, serum galactomannan, blood and sputum culture, the culture sensitivity.
Continue.
On the day 2 of admission, continuous fever spikes were present. His blood pressure was 150 by 90 mm of Hg, and heart rate was 137 beats per minute, respiratory rate of 35 per minute. And he was started on intermittent NIV support with FiO2 of 0.6 and PEEP of 8. There is a plan of bronchoscopy plus bronchoalveolar lavage, which was not done due to logistical issues.
I think Goutham, do you think BAL can be safely done in the given clinical context? I just go back. I think you haven't.
No, sir. No, sir. We explained the risk of intubation and further plan of bronchoscopy to the attenders.
So yeah, probably he's becoming more tachycardic, tachypneic. Oxygen requirements are increasing. It may not be.
Yes,
he's on NIV, and it may not be safe to do a BAL at this point of time. If at all it needs to be done, he has to be intubated, and BAL needs to be done. Okay.
On day 3, gastroenteritis settled, but fever spikes continued. Patient was tachypneic with respiratory rate of 39 breaths per minute and tachycardic with 124 beats per minute. Plan of intubation has been explained to attenders where they are not willing for intubation, and they have opted for a do not intubate and do not resuscitation protocol, and thus we have continued an intermittent NIV support. The H1N1 and COVID-19 RT-PCR reports came out to be negative, but the serum galactomannan was positive. Hence, the antifungals has been escalated to injection voriconazole. The rest of the treatment continued to be the same. Ophthalmologist referral was given, and fundus examination was done, which was normal and no abnormalities present. Blood and sputum cultures were professionally negative and showed no growth. The NIV support continued, and again induced sputum was stained for culture and sensitivity, AFB, gram staining, fungal staining, and gene expert.
On day 4, fever spike was still present. Patient continued to be the same with tachycardia and tachypnea, requiring intermittent NIV support and 15 liters of oxygen with NRBM. Patient attenders were counseled again regarding the need for intubation, for which they agreed. And we have intubated the patient and started on mechanical ventilation. Now the plan of bronchoscopy was there. And plan of this blood sputum, PCP stain, cryptococcal antigen, gene expert, beta D glucan, which were negative. But unfortunately, the attendants, due to some financial constraint, they took the patient in Lamas.
Are you planning to present the other one also, or the patient? Or should we just...
Can discuss this case, sir, the different scenarios.
Okay. Sure. So how do you broadly approach infections in an immunocompromised host? What is the definition of immunocompromised? How do you categorize them? You have some format in which you approach.
Like a risk stratification, sir, low risk and high risk patients, or?
Okay, what do you mean by high risk patients? Who are the ones who are high risk for infections?
Patients who have a MASCC score of less than 21, more than 21, and a patient who has a hemodynamically unstable patient.
So I think we'll forget about whether the patient's got HIV or not. We are looking broadly at a host who's immunocompromised. So the immunocompromised state can be due to a disease that causes immunocompromised state or the treatments that we give. So I'm talking about broadly. These are all secondary immunocompromised states. Okay, we're looking at immunocompromised by disease or immunocompromised by therapy. Let's look at therapies that can cause immunosuppression. What are the different subsets of therapies that we now have in our armamentarium that can cause immunosuppression? Common ones, and then we'll go on to some uncommon. Is that the most common one?
Chemotherapy drugs.
Is that the most common one? What is the drug which is more abused?
Steroids.
Steroids. So corticosteroids are the ones which is one class of drugs. Okay. Next is chemotherapies. Therapeutic drugs. Okay. What are the other classes of drugs which can cause immunosuppression?
Cyclosporine.
Those are all immunosuppressive drugs, no?
Yes.
Okay, I have made some points on the classes of drugs which can cause immunosuppression. Because you said steroids. The second one is chemotherapy, and that can cause both lymphocyte depletion and neutropenia, which can predispose the host to infections. Anti-lymphocytic antibody therapies, okay, like rituximab, quite commonly used now. Then monoclonal antibodies against T cells, B cells, or combination against T and B cells. Anti-cytotoxic cytokine therapy, not anti-cytotoxic, cytokine therapy. We use tocilizumab left, right, and center during COVID. So IL-6 receptor antagonists, TNF. So those sort of therapies can also predispose to infection. Then JAK inhibitors, monoclonal antibodies to complement. And interestingly, one of the drugs that was listed as causing an immunodeficient state is phenytoin. 20% of patients with phenytoin have a reduction in immunoglobulin A. So if you look at drugs, the classes of drugs, these are classes of drugs that can cause immunosuppression. What are the common diseases that can cause immunosuppression and why?
Rheumatological disorders.
Sorry?
Rheumatological disorders.
Yes, all hematological disorders, because immunity is mediated by T cells, B cells, Okay, so adaptive immunity, innate immunity, all those can be affected due to hemopoietic cell disorders. What else?
Any autoimmune diseases, diabetes mellitus,
Yes, diabetes, autoimmune diseases. What else?
chronic kidney disease,
Chronic
or
kidney
any
disease. Yes.
malignancies.
Lymphoma, leukemias.
Lymphomas. Which lymphomas primarily? CLL can, myeloma can. Anything which causes you to lose proteins. So nephrotic syndrome, protein losing enteropathies, asplenic states. So all these are, so if you look at it as, immunosuppressed by therapy or immunosuppressed by disease, then it becomes easier. Then there are the primary immunodeficiency disorders, that which affect antibody production, or that which affect cell-mediated immunity, or the complement system of phagocytosis. There are several congenital disorders that can predispose to infection. So we are looking at congenital and acquired immunosuppression, and that should be probably a broad approach. That's the way I would like to look at. Dr. Sivakumar may be able to give us different approaches. Dr. Sivakumar, if
I think this is okay, sir. I think we'll.
Okay. So if you look at disorders broadly, what type of immune disorders predispose to what type of infections? How do you look at it? Is there something which predisposes somebody to more viral infections or bacterial infections or fungal infections or opportunistic infections? And of course, HIV is the classical example where as the CD4 count drops, you get more and more, severe opportunistic infections. Okay. So is there some way you can sort of look at what sort of predisposition is there with some type of cellular dysfunction? Let's look at neutrophil dysfunction.
Bacterial will be the most common.
Bacterial will be the most, yeah. So where there is affection, where there's a problem with, phagocytosis. Okay, so yes, so neutrophil dysfunction can cause more bacterial infections. What about other infections?
T cell will be a viral infection.
Which one?
T cell in disorders.
Okay. Other immunosuppressions or immunosuppression or suppressive therapy? See, bacterial and viral by and large are the common ones in any immunocompromised host. But as the immunosuppression is more intense, you start getting the other opportunistic infections. So if you remember it that way, bacterial, viral, common for everything, immunocompetent and immunocompromised hosts. And then you look at other opportunistic infections as you go down the list. More, as Sir was also saying, nocardia, listeria, legionella, then all the fungal aspergillus, histoplasmosis, and then the opportunistic viral infections, BK, JC virus in the transplanted host. So your list of differentials in each of these, you should have a bucket of possible organisms that can cause infections. And then based on the clinical state, the type of immunosuppression, or if you're doing transplants at the stage of the transplant period, whether it's at the induction phase or whether it's a post-transplant period, it's an autologous transplant, then you have early transplant period and the late transplant period, the infections are very different. I came across a very good review, which I will post it on the chat box, which I think you should all read if you want to know immunosuppressed infections in the immunosuppressed host. I'll send that across. Dr. Sivakumar, I'll just hand over to you while I do that.
Sure. Other things probably, as Sir said, I think probably start with viral and bacterial, and probably as the immunosuppressed stage becomes more intense, we have other organisms. We talk about PCP, we talk about various funguses like coccidioidomycosis, cryptococcus, and probably some protozoal infections also. Probably we come across, if the immunosuppressed state is very severe, we come across infections like toxoplasmosis. So these are the various things to consider based on the severity of the immunosuppression, and if it is a solid organ transplant, based on the timeline. I think we can have a differential diagnosis.
I think we'll pause here and take questions, because broadly we have given you an approach, and I think the spectrum will depend on the etiology that you suspect. It also depends on how equipped your laboratory is to screen for the various viruses, whether you can screen BK and JC and other than influenza. I think most labs can do influenza and multiplex PCR for respiratory viruses, but beyond that, the other opportunistic infections may be difficult. Fungal becomes a bit challenging, particularly in the immunocompromised host. We use a lot of galactomannan to guide our diagnostics, but it's a combination of the clinical setting, high resolution CT scan imaging, which may show a fungal pattern, a bronchoalveolar lavage, which also supports, although it's very difficult sometimes to prove invasiveness. And that is one of the characteristic features. We never talked about mucor in the diabetic host. I think that is something, again, very common, which is not thought of. So the clinical setting, as you very rightly pointed out in your discussion a little earlier on, there are so many disease processes which cause an immunocompromised state. We don't classically bucket them under immunocompromised. We say, unless they have HIV or they have high-dose steroids, we don't call them immunocompromised. But there are a whole lot of diseases where they are immunocompromised by the disease. Diabetes, classical example, or nephrotic syndrome. So we need to enlarge our list of differentials that we think, depending on the host problems. I also am reminded of one of the teachings of my teacher, who said the drug, the bug, and the host. So we are looking only at host factors in terms of what predisposes them. We also need to look at virulence factors of the organisms. With the use and misuse of antibiotics, we are certainly seeing a lot more virulent organisms, much more resistant organisms, from MRSA to VRSA to VREs to multi-drug resistant bacteria across the spectrum. So the bug is the second important component. And the third is, of course, the drug. So you can only choose an appropriate drug if you know what you're dealing with. And it is very important that unnecessary antibiotics and antimicrobial agents are not used. Dr. Sivakumar, want to add anything more? Dr. Venkat?
Sir, I think we in the exam, what I actually came across when the students get questions or cases related to this, sometimes they find a case of post-renal transplant, post-liver transplant. The cause why the case was given to them is not about more related to this immunocompromised host only, but it is more related to the critical care. So many of the times the student, the moment they see a post-liver transplant, they get panic, thinking that they will all be asked about the transplant-related things only. But it's more of a transplant case and the critical care related to that. So it again boils down to basics in critical care will be most of the times will be evaluated in their assessment than going to the transplant. And maybe, as you said, sir, infections will be one of the common reason why these patients comes to us in ICU. So now we are seeing more cases of both liver and renal transplant, post-renal transplant cases come. The second is hematopoietic transplant. I think you should be guiding us. These cases also do come as either post chemo to any hematopoietic malignancies or bone marrow transplant. They again are the second set of cases which comes. The third is many of these are post chemo malignancy cases after the surgery or before the surgery or some palliative chemo. These are the set of cases which comes. So what happens is when in our ICU, when DRNB or IDCCM or IFCCM exams we conduct, when these exams were conducted on the physical form, now we are slowly moving towards physical form in DRNB. So whatever cases are available in the ICU, they try to allocate one of the case. And the moment the students see this case being a post chemo case or a malignancy case or something, they get into that there is a big list of chemo agents been given, and they get into that trouble. So we will like to know from you, how do the students approach in these cases? Because I have seen many students who get completely nervous, thinking I have never prepared this case, and they lose the battle there in that self. So I want you, both of you, to guide on those aspects to, in a broader way, how to classify from a innate immunity to humoral immunity, T-cell mediated immunity to antibody mediated immunity, and complement levels, and maybe a general idea of even the immunocompromised host itself, whether it is an acquired or it's a congenital one with common variable. In that angle, if you guide them, that will help them. JVP sir, can you throw some light on that? Help them.
The voice is breaking up quite a bit, so I understand that you want some guidance on what you do if you're dealing with a, say, solid organ transplant or a hemopoietic cell transplant. Is that your question?
Yeah, I'm sir, am I audible now?
You're audible, but you're breaking up too much. Maybe it's connection from my side. I don't know.
No, maybe. Sivakumar, are you audible to me?
Yeah, you're audible, Venkat, but slightly breaking in between, but you're audible. Sir, Venkat want to know a general approach to this various patients who are immunocompromised, who comes to ICU, who could be an exam case. That's what he want to give an exam. We want to give an approach to this exam going students about various patients who come with an immunocompromised state, starting from HIV to solid organ transplant, post chemotherapy. For all these patients, for the exam going students, just Venkat want an approach to them.
See, I think I'm now posted in an ICU which has 5 post-transplant patients, BMT patients or stem cell transplant patients. And one of the challenges we face with hematological, I'm talking about hemopoietic transplantation first, is that hematologists worldwide hit them with everything that they can think of. It is rapid escalation from morning to evening to night. So if a person is having the first spike of temperature, we look at primarily first covering bacterial infections, gram negatives being the most common, and now resistant organisms are also common. So you start with ESBL coverage. Carbapenems is what you first start with. And if there is resistant organisms that you're suspecting, you quickly escalate to polymyxin or colistin. And if you have a positive culture or the person is deteriorating very rapidly, ceftazidime, avibactam, along with astrinam is also being used. And of course, gram-positive cover when they have their next spikes. But most often, the challenge is you don't grow any organisms in the post-transplant setting. And so a lot of therapy is empiric, based on the clinical setting, whether they're in shock, whether they've got organ dysfunction. And the next level of escalation then starts happening. If there is evidence of CMV, appropriate cultures are taken, PCR is done, and then the add-ons come with that. So I can't give you this is the line in which you go. Bacterial is covered first, then the rest of it is based on the investigations, the clinical profile, because everything is common. Viral is possible, fungal is possible, Mycobacterial is also possible, though we don't see too many of that in the immediate post-transplant period. Sivakumar, you want to add anything more on the hemopoietic?
Venkat, I think as you rightly said, the difficulty with most of the exam going PGCs, unless you're in place like Vellore, you're not exposed to transplants. Probably, if at all, they're exposed to this to both renal and liver a bit. They are not exposed to HIV, and probably now there is a frequent exposure to biologicals. So that's why they get a bit nervous whenever they get a post-transplant patient or a post-chemotherapy onco patient. So I think better would be approach the basics in the same way with certain specifics to these immunocompromised patients. So most of the things, the basic with regard to resuscitation or antimicrobials, all this will stay the same. And there will be certain specific aspects with regard to probably an HIV patient or a transplant patients. I think there are certain specific what to expect, how to evaluate, how to treat. Apart from that, rest of the things stays the same, and probably by the face value, if you get a case, I think many of them, they get probably nervous. They need not be so. Probably the basics are same, and probably they need to know some certain specific about these group of patients to handle the exams.
Yeah, true, sir.
I fully agree with Dr. Sivakumar. The thing is, I think it's best for trainees to say bacterial infections are still common in the immunocompromised host.
I think that's a very important point. I think you are repeatedly re-emphasizing, sir. The common.
Okay, so that is the first point.
Yeah,
common organisms are common. So gram positives, gram negatives, you must cover.
Sir, can you hear me, sir?
We're breaking up, but I just wanted to reiterate that bacterial infections are still the most common infections in the immunocompromised host. So you must have appropriate gram negative and gram positive cover. On top of it, as Dr. Sivakumar so nicely put it, what is the host problem? And you know what are the common infections that come in that particular host problem, whether it's a solid organ transplant or hemopoietic transplant or therapies that have been used for other diseases. And then a very systematic evaluation of the potential cause. You don't need to jump in and hit them with a combination of both, say, an echinocandin plus voriconazole or amphotericin and ganciclovir without doing the necessary investigations. You do get time for that. It's not that they crash like that. Bacterial, less, you don't have much time to cover. So you may need to start very broad, and then based on sensitivities and cultures and sensitivities, you may de-escalate. But the other things do give you time to evaluate and then add on as therapy. Certain conditions where the immunosuppression is very severe, there may be a role for PCP prophylaxis, there may be a role for candidal prophylaxis, and that again is based on the clinical scenario and setting. That much, if you answer for your exams, that's enough. People are not going to say, how do you, diagnose, let's say, HHV7 infection and how do you treat? Or when do you get coccidiomycosis in a HIV infection? They're not going to go that deep. So I think broad concepts presented well, even in an exam, is enough. And most of us consult specialists to help us in our understanding of what could be the possible etiology. For example, a person develops diarrhea post-transplant after 30 days. What could the differentials be? The common bacterial pathogens that can cause infections, viral, protozoal, Clostridium difficile, okay, graft versus host disease. So systematically go through what could be the possible differentials based on the site of infection, whether it's GI or lung or bloodstream infections, whatever it is, go through systematically. These are the potential differentials. I think that will make it easier.
So there are one question in the chat box, like starting of antifungal in an immunocompromised host. When do we start? What is the rationale? So can you hear us?
Yes, I can hear you. It's I'm not. I don't have a very clear answer to this, Dr.
Siva.
So sure, you want to take this?
particularly if you take it in the context of neutropenic as well, probably we may not be straight away starting an antifungal. I think we straight away start with antibacterials, and if 5 days of therapy still there, probably if they still are septic, hemodynamically unstable, that is the time you consider an antifungal. This is in a neutropenic background, but the other patients, I think, like generally, like any other, where you look at probably a risk factor for fungal infection, if already they're exposed to antibiotic, those kind of group, probably you might straight away consider an antifungal. Otherwise,
so one of my teachers used to tell us, in an immunocompetent individual, think fungal in a surgical patient in the second week and in the medical patient in the third week. Of course, we are seeing changing trends because we overuse antibiotics that may have shifted by several days. But in a purely immunocompetent individual, you don't think of antifungals early. And just taking on a little bit from what Dr. Sivakumar said, if you again look at what possible focus, if you're looking at an immunocompromised host, say post-transplant, if there is a respiratory worsening in a post-transplant setting, what could it be? Bacterial? It could be viral, interstitial processes, or a fungal. If it's bacterial and endotracheal aspirate, will be able to give you some idea based on the colony forming units and based on the pattern of distribution of the opacities, whether a bacterial is more likely or not. Again, viral, you can send your CMV and look at other viruses, multiplex PCR, as I said earlier. And if the pattern is very suggestive on a HRCT of a fungal, then you start amphotericin. Of course, candidal infections of the lung are very, very uncommon. So please don't say in the exam, this is candida, exams is candida pneumonia. It's not very common. Candidemia is common, but candida infection of the lung is not common. So it is dependent on the clinical setting, the timing, and the focus. Your choice of antifungal or a decision to use antifungal.
So there is one more question: CD4 versus CD4 to CD8 ratio, starting in empiric therapy in immunocompromised host like in this RVD. Which one is better, and what is anyone we are practicing right now? CD4 versus CD4 to CD8 ratio.
I'm not aware of this. Sorry, Dr. Sivakumar?
no idea, sir. I think probably.
I also don't know. It's a very fine question for a ID person. This is too intricate.
So I think, sir, with this, we made some clear points that the common organisms still remain common even in immunocompromised host. So you said community acquired organisms which are common for the immunocompetent still remains common there. And in exam, when we come across cases of immunocompromised host in the form of, as we discussed, like whether they are a solid organ ones or a hematopoietic transplant ones or a post-chemo derived ones to the neutropenic, all these categories may come to your ICU, but you will not be evaluated for the expertization in that area by your critical care in that area, or sometimes the evaluation of your infections in those areas. So you need to be experts, or you need to be expertise in that area. The other discussion, sir, as in most of the solid organs, there will be probably timeline between a first month to 6 months and more than 6 months. So in an initial month period, most of the organisms or infections are related to your hospital acquired, surgical site related, or your nosocomial ones. Whereas from 1 month to 6 months, it may be your most of these opportunistic infection which are common. And beyond 6 months, we see most of these community acquired infections which are common. What is your take on that, sir? We may see an overlap in them, and many of those organisms which has been leveled as common in 1 to 6, but because of we cover them with cotrimoxazole and sometimes valganciclovir, depending on the positivity of IgM, we don't see them very frequently because cotrimoxazole covers most of those immunocompromised, those opportunistic infection, including your pneumocystis carinii pneumonia in that period. So this classification related to a less than a month to 6 months, and a more than a 6 months. Any take on that?
Yes, I think it's becoming a blur because of our understanding of how prophylaxis works in these situations. I think we have evolved a long way from the time when we used to use norfloxacin prophylaxis for recurrent UTIs to now using azole prophylaxis or cotrimoxazole prophylaxis. So there is certainly a shift. There is also a change in the time of occurrence of this infection, and not only that, there is a shift in the type of organisms that we are seeing. Some of the organisms that they told me this week, I have not even heard of some new viruses. I have to go and read up. So we are seeing more and more opportunistic infections because a lot of this is modulated by therapy and newer therapies that have come over time, and more intense immunosuppression, like, spectrum of infection that was seen with tocilizumab, many didn't see. And, so I think the type of cytokine, anti-cytokine therapy that we are seeing, or monoclonal antibodies, the opportunistic infections are very different.
Venkat, I think with regard to solid organ transplant, in addition to what you told with regard to various timelines, probably in the early days, probably you have to keep in mind probably infections related to the donor. That is also one thing you need to keep it in mind. And probably subsequently, maybe graft versus host disease also probably has to be considered in certain patients. I think this is with regard to different timelines.
Yeah, non-infective causes which mimic many of these infections, including resection, graft versus host disease, and sometimes maybe surgical related complexities, anastomosis related complexities, and even vascular related complexities, which may look like it is like infection related deterioration. So those all will come as a mimics and differentials for any sepsis in this kind of immunocompromised host. So the other question was related to your discussion, Dr. Sivakumar. When should we consider MRSA and Pseudomonas infections?
Subsequently, probably, I think when these patients are hospitalized and probably when they're in hospital for some time, that is the time probably you could consider these organisms. But for MRSA, as we talked, I think the distinction between the community and the hospital is bit blurred recently. But generally, probably you won't consider them on admission. But since they are in hospital and they are in hospital for quite some time, that is the time probably you should consider these hospital-acquired pathogens.
Yeah, and particularly the neutropenic septic patients, more of if they have any CVC access or a central line access with a long term, they're probably considering a gram-positive cocci being a common phenomenon other than your DNB, which are seen. And skin and soft tissue infections or some mucosal loss. I think these are the few things where IDSA suggesting you may consider covering this gram-positive cocci more often than commonly.
Yeah, particularly when they have an invasive devices and which are there for some time, like indwelling catheters, like PermCath, all those probably, or some chem ports. Suppose we have a chemo port which is there for quite some time. Those are situations probably you will consider covering MRSA as well.
Yeah. So the other thing is in diagnosis, one of the common things which we see in this immunocompromised host, because they give a less time, we will be generally more aggressive than what we commonly don't do in a normal immunocompetent host. For example, in a immunocompetent host, a day 1 or day 2 of fever of 100 or 101 can be just a symptomatic management with probably waiting for a syndromic approach, saying is it a lower respiratory tract infection or upper respiratory tract infection, and then most likely it is a viral. So after 2 days, we try to see whether it is a dengue or a malaria to initially. But probably that same thing may not hold good in a immunocompromised host, where on day 1 with the underlying immunocompromised state, evaluate them, and probably the investigations will go a little more aggressive than what we see in an immunocompetent, including not the routine cultures, but sometimes may use the PCR based techniques a little more aggressively, and also sometimes more imaging, just not X-ray. As you said, X-ray can be many times blurred and may miss in that. So going to the imaging, like sometimes CT scans. So more aggressive imaging is preferred when you have a very sick and immunocompromised host over that. So any take on that from both of you, sir? Not just from blood point of view, but even imaging point of view or evaluation point of view. Dr. Sivakumar.
Venkat, but there are certain limitations with regard to culture in these patients, because many of them are fungus and many of them grow late. Probably you can't rely too much on cultures, and probably imaging will be helpful. And there are a lot of PCR based tests which are recently available, which could be very useful in these patients. And again, apart from this, I think it is your high index of suspicion, probably, and the host factors which are very important in deciding the initial therapy. Probably all this can be useful. Probably some of them you may not be able to do initially. Probably they may be unstable. And certain tests, many of them like cultures, takes time. Particularly these organisms like fungus, they all take time to grow. PCR could be useful in some of these patients.
Sir, any take from you, sir, on this?
And I agree with Dr. Venkat that time is the essence in an immunocompromised host, and often you do not have, and Dr. Sivakumar also echoed that we can't wait for the results. And so I go back to the same thing I've been telling so frequently. What is the underlying problem? What are the most likely etiologies? What are the investigations that we can do to support the diagnosis? We do a lot of HRCTs. I know it's not easy to take them down for HRCT, but the pattern of involvement sometimes does help to say whether this is PCP or, a good radiologist will tell you this radiological features seem to be consistent with PCP, and sometimes we have had to send a second sample when we have picked up rather than the first one didn't show PCP, or this is more like an aspergillus, or this is more like a CMV pneumonitis. So there is some guidance through radiological, and it's very difficult to rely on, as Dr. Sivakumar said, cultures. PCRs, yes, they do help, but cultures. And quite often in an immunocompromised host, you're scared to stop anything because you're worried. Am I not covering? And when they're spending several lakhs of rupees for a transplant program, you don't want to lose a patient just because you have not covered for a particular infection. And often you tend to overuse antimicrobial therapy. I'm using the broad term antimicrobial rather than using antibiotic therapy because it's a cocktail often of gram-positive, gram-negative, an antiviral, an antifungal, one or two, and an antifungal. Yeah, antifungal. I already said antifungal. Okay, I think I've said everything.
Yeah. So, regarding the last component of treating these patients and treating with a little broader way, as you said, look for the source, look for the possible organisms. But in an immunocompromised host, the spectrum widens than what we see in an immunocompetent host. And as you said, we probably at the beginning or after 48 hours, 72 hours, as Dr. Sivakumar said, we keep on adding, escalating, because cultures sometimes take time. We don't know what are we dealing with. Sometimes we are also hesitant to de-escalate or drop down till we get some conclusion. Majority of the times we don't get any clue. So we tend to land up in continuing this major combination of 3-4 antibiotics or antifungals, combination of antifungals. So how do we take a de-escalation task in them? Procalcitonin guided, negative predictive value of beta-glucan values in this kind of context, or what will be the role of them?
Again, we have to reiterate that common things are common. We recently had an admission on a post-transplant patient, had high spiking fever, bit of shock. They transferred early. And all we did was remove the 17-day-old central line and resited it, and fever crashed. So, common things are still common. I don't think we should give too much emphasis on antibiotics. Try and find out a focus. It may be a skin and soft tissue infection. It may be a catheter-related bloodstream infection. It may be a COTI. I think do not take a shortcut and say, since it's immunocompromised, we have to give the entire spectrum of, medications. And I was pleasantly surprised when recently another patient had become afebrile. They said, okay, let's de-escalate. He doesn't need ceftazidime avibactam anymore. Let's de-escalate. So it needs courage also to say when the temperature settles, when the SIRS signs settle down, okay, let's slowly one by one remove to see what happens. So procalcitonin guided therapy may be tough in an immunocompromised individual. You will go by organ dysfunction, organ function, your immune state is improving, like your counts coming back, the temperature settling down. So you are guided by a whole lot of things. And sometimes you may say, okay, the patient still looks a bit toxic, bit sick. Let's not stop the antibiotic today. Let's continue for a little more time. So that would be my approach rather than saying, you are totally guided by one parameter or two.
Dr. Sivakumar, what is your take on 1,3-beta-D-glucan being used as a 1,3-beta-D-glucan test used as a negative predictive value for the fungal to drop, antifungal to drop?
Okay. The thing is, I think to add to what Sir has told, I think source control is very important. And with regard to antimicrobials, I think the de-escalation becomes easier if you have a culture positivity and patient is making a clinical progress.
True.
In case if there's a culture negative sepsis and patient has not made a major progress, I think that time I think the de-escalation becomes probably difficult, and it has to be more clinical at that point of time. That is one. Two, with regard to de-escalation based on biomarkers, particularly procalcitonin, most of the time, I think probably we have not done a baseline procalcitonin many times, I think, and then to do a de-escalation based on it is not possible. So for as far as the postgraduate here, I think the de-escalation, I think you get your cultures, you make a clinical correlation. I think at the 48 to 72 hours, you make a decision based on whether you should continue, stop, or probably broaden a bit. So it is again difficult in a culture negative. With regard to biomarker, with regard to beta-D-glucan, the problem with beta-D-glucan is the availability. In many places, I think whether it is galactomannan or beta-D-glucan, the availability is an issue. So many of the places, I think many of them, I think the availability is an issue. And once it is available, probably
it can add on to your clinical judgment.
Yeah. To next. See, many places, I think even in most of our places, I think except for metros.
As you, Peter sir, as you rightly pointed out, whenever we handle with an immunocompromised neutropenic patient, we try to actually restore their immune function as early as possible, which will be one of our weapons to handle this infection. So in those many contexts, there will be colony stimulating factors which has been used in this kind of neutropenic patients, particularly which are induced by chemo agents. And in this septic patient, we have taken through a lot of controversial or kind of the robust evidence is still lagging whether these colony stimulating factors play a role in packing this neutropenic patients to a good immune status, or that may be helping. What is your take and what is your practice there in using of colony stimulating factor in the severe neutropenic patients?
No, they routinely use it. I agree that, in once a patient has had an episode of neutropenia and sepsis and septic shock, it may not be very beneficial. But I'm apart from colony stimulating factors, I'm seeing an increasing use of Buffycoat during very severe neutropenic periods, where they use pooled Buffycoat. Sorry?
Leukocytes?
Yes.
Yes, I think that's what is my question.
So that is being used, and the hematologists do claim that there is a benefit. I have not seen enough of use for us, because by the time they come to the ICU, they're much sicker. But in the post-transplant period, they do use a fair amount of Buffycoat, and they claim some success. Regarding, I'm going to go a little tangentially to the question that has been asked by Dr. Santosh about immune reconstitution and other syndromes which are hyperimmune response that you sometimes see when engraftment takes place. And often it's very difficult to tease out whether the worsening respiratory function or SIRS is due to an infection versus an immune reconstitution or a syndrome similar to that. Of late, after much discussion and deliberation, when we are sufficiently ruled out an infection or we are powered appropriately with a broad spectrum antimicrobial therapy, enhancing immunosuppression seems to have got some people out of very critical states. Even in the last few weeks, we have had a couple of patients who are very sick where a small dose of methylprednisolone or a good immunomodulatory dose of methylprednisolone has got them out. So, again, how do you balance this out? How do you determine it's this or that? It needs a lot of time at the bedside, a lot of dialogue amongst your colleagues to then weigh what is the risk versus benefit, a constellation of team of intensivists, infectious disease people, and hematologists or the primary treating oncologists dialoguing to say what is the risk versus benefit. Can we enhance immunomodulation versus backing off a little bit to see whether the infection will respond? That's always a very, very difficult task for us.
Okay. Any questions from Goutham and Kausalya from your side? Okay. So I think we had an enlightening discussion. So the take home is whenever you come across these cases in your exam, first thing is don't panic about, just go through what kind of immunocompromised state it is, whether it is innate immunity, acquired immunity deficiencies, whether it is a solid organ transplant related issues with probably a immunosuppressive agents or a bone hematopoietic stem cell or a chemo, classify them, see whether, as we said, T cell mediated, antibody mediated, what kind of immunocompromised state and what are the common sources in these patients, whether as we discussing whether it is a lung or a skin and soft tissue, a line is there, CNS, or what is the source, and from there your empiric choice may start. It may be initially broadened, and then evaluation will be aggressive, probably with more imaging, more kind of lab investigation, but over a time it can be narrowed down on the basis of your cultures. But once your cultures are negative, as both the moderators were trying to explain, it will be a little difficult in immunocompromised mode. That will be a combination of both clinical and then add on some adjuvant role of both if you have a baseline procal or a negative beta-glucan. So I think with this, we thank both Goutham and Kausalya in bringing this discussion and a case. And I thank both Dr. J.V. Peter sir and Dr. Sivakumar in spending time and interacting with our students, sharing their experience and knowledge. So we thank both of you from bottom of our heart for participating and sharing your knowledge with our students. So thank you all.
Thank you, Dr. Venkat. Thank you, Dr.
Thank
Sivakumar.
you, sir.
Thank you, sir.
Thank you, sir.
Thank you, Venkat. Thank you.
Thank you.